Well, good afternoon, ladies and gentlemen, and a warm welcome to all the delegates to Cape Town. It's wonderful to have so many logged on over here this afternoon, and we look forward very much to Dr. Peter Barrow, who's at the Wits Donnie Gordon Centre, and he's going to be speaking about gut instinct. Now, we've had a few speeches and talks on metagenics and the and also zoonosis and things of this, probiotics, and also the gut biome. So it's wonderful to have him over here. He's an expert. He's a GIT specialist. He's spoken widely abroad and worked abroad, and he's a trainer and teacher and specialist at the Wits Donnie Gordon. Just before we begin with Dr. Peter Barrow, it gives me great pleasure to have our sponsors this evening. That's Belinda in the form of Metagenics. They're going to say a few words on their new product, Ultraflora Regular Probiotic. Thank you very much indeed. Take it away, Belinda.
Thank you. Good afternoon, and thank you for this opportunity again. I'm very excited about today's topic. The microbiome plays such an important role in overall health, and I'm sure that most of you see a lot of patients with gastrointestinal symptoms in your practices. So today I'd like to introduce our new probiotic for patients struggling with sluggish gut motility and irregular bowel movements, Ultraflora Regular. So Ultraflora Regular contains the strain B. lactis HN019 at 5 billion CFU per capsule. So this strain has been shown to enhance gut motility. It improves peristalsis by increasing serotonin levels in the gut. And it also stimulates digestion, improves gut flora, and can reduce inflammation. So not all probiotic strains are created equal, and each strain has its own unique strengths. Therefore, it's important to ensure your strain you choose for a particular indication has quality research to show efficacy for that indication. And this is what sets Metagenics probiotics apart. So today I'd like to discuss two studies which illustrate why B. lactis HN019 is the best choice to assist patients with irregular bowel movements. The first study was a randomized placebo-controlled study which looked at a dose-response effect of B. lactis HN019 on whole gut transit time and functional GI symptoms. There were 100 patients in the study divided into three groups: placebo, a high dose, and a low dose. It was a 14-day study. And as can be seen by the graph, both the high and the low dose had a significant improvement versus placebo. So the strain was found to be well tolerated, decrease whole gut transit time in a dose-dependent manner, and reduce the frequency of functional GI symptoms. So patients had more regular bowel movements and less gut discomfort after taking B. lactis HN019 daily. The second study was a meta-analysis published in the World Journal of Gastroenterology. This meta-analysis's aim was to determine the efficacy of probiotic supplementation on intestinal transit time and included 15 clinical trials and 675 patients. The results showed a medium to large effect with the strain B. lactis HN019 and B. lactis DN173010, while the other strains yielded negligible results versus control. So probiotics can be an effective way to improve bowel frequency, provided we use the correct strains with quality research for this indication. So please remember Ultraflora Regular. Sorry. Yeah, so I just want to say, remember Ultraflora Regular for your patients with functional GI symptoms and irregular bowel movements. And then I also wanted to remind about Ultraflora Women's for urogenital health, which we spoke about last time, as well as Urodyne for the management of symptoms of UTIs. And then we've also got Estravera for menopausal symptoms. Thank you. And my details are on the screen if you'd like to see a Metagenics representative.
Belinda, thank you very much indeed. And on behalf of Metagenics, wonderful to have you here as a sponsor. And I'm hoping you're going to enjoy the talk by Dr. Peter Barrow. While Chris is loading Peter Barrow's slides, I'd just like to say my name is Peter de Jong. My co-host tonight is unfortunately unable to be with us.
Sorry, Peter, I am on. Yes, I am on, but I'm working remotely today. So,
okay,
but I am on. I'm glad to join. Yes.
So Steve Jeffrey is working remotely, and it's wonderful to have you with us then, Stephen Jeffrey. So without further waste of time, Dr. Peter Barrow of the Wits Donny Gordon Institute, a GIT specialist, gut instinct, the gut microbiome at midlife in health and disease. Thank you very much indeed.
Peter, I hope I'm not muted, am I?
No, you're loud and clear. We can see you and hear you. Thank you, Peter.
Okay, great. Well, guys, thank you very much for inviting me to talk to you guys. And I'm always amazed by who's interested in the microbiome. I'm a gastroenterologist, and by default, I had to get involved in the microbiome through our work with fecal transplantation with resistant C. difficile.
Well, if I can just, we were talking about this last week, in fact, how difficult it is to get somebody involved in fecal micro transplantation with some experience in it. So I'm hoping you're going to say a few words about it, because it's always been a topic close to our heart, as it were.
No, very, very much so. And in fact, that's what started us. The whole story with that was a patient who needed it, and there was nobody doing it. So the patient donated their own liquidizer, and we literally started from scratch. That was going back to around about 2014. So we've been doing it now for 12 years. When the first reports came out, and I'll actually show some of that stuff. But I'm not a microbiologist at all. So I get very confused with all these names of Bifidolactis HN019 and all the different names. So when I butcher all the bacterial names, please forgive me. I hope there are no proper microbiologists on, but I'm going to give you a practical overview of how I approach the microbiome, and we'll talk a little bit about what we can do to try to manipulate the microbiome when it's appropriate. The first talk I actually was asked to do was actually to the psychiatrists, and I'm not sure if there are any psychiatrists on tonight, but I think pelvic floor dysfunction and psychiatry does go together a little bit. I'm doing a talk later this month to the sports physicians, because they want to know what's the optimal microbiome for an athlete. And there's a whole lot of info that's going into this microbiome, which is actually amazing. So as an introduction, I'm going to really briefly go about an introduction to the world we live in, and bacteria and archaea and what actually is a microbiome. I'll talk a little bit about microbiome and health and disease. Why I got asked to talk to you guys was through my talk at the Menopause Society. So and I'm going to show you some quite interesting data regarding microbiome in menopause and its role in osteoporosis, etc. You briefly mentioned vaginal candida and health, and how probiotics may help there, and why these changes are very important, particularly in midlife of women, and then generally how we can improve our microbiome. And I'll talk there a little bit about fecal transplantation. So to start off as an introduction, I don't know if you know, but the world started 44.5 billion years ago. So that's quite a big number. It's 4,500 million years ago. And you mentioned politicians. At least I hope I didn't butcher that one, but that's how long ago.
You were very close.
That's a long time ago. But to try and make this simplified, you've probably all done this exercise. You can condense the year into, if you condense this 4.5 billion years into a year, human beings have only been around for the last 30 minutes. And when I was doing this talk for the Menopause Society, it was around about New Year. So I was thinking about New Year's Eve and fireworks. Fireworks were only invented 9 seconds ago, if it was on New Year's Eve. It's interesting that dinosaurs became extinct on the 26th of December. But what's interesting is plants evolved in October. And plants were the first visible living organisms. So before plants, there were no visible organisms. But life actually started on Earth in March. So during that time, from March to October, it was the microbes that ruled the Earth. And what's quite interesting is the last 30 seconds, that's considered the Anthropocene period, which is basically the period where humans are impacting the earth. And I can go into a whole story about climate change, but it's our human impact in the last 30 seconds that's making the biggest impact on the earth at the moment. And if any of you guys really want to know about this, there's a very good book called I Contain Multitudes by Ed Young. So he's a guy that's actually sort of popularized the microbiome in general media. It's a very good book to read. But basically, you could argue that we are still actually living in the microbiocene period, which has been described as starting at the beginning of the dawn of life and will probably carry on until the very end, even after the humans have wiped ourselves out. So what actually happened and what is life? In March of that year, two domains started. You got bacteria and archaea. Archaea are the latest identification of human or of living organisms. And it was around about July when these archaea and bacteria joined together to create eukaryotes. So eukaryotes were basically a combination of bacteria and archaea, with the archaea acting as this chassis and the bacteria providing the mitochondria. And it's basically from this combination of bacteria and archaea that all visible life evolved. And basically you're developing now a eukaryotic cell, and this visible life now allowed for these other bacteria to hop on them, and they've been hosting bacteria since around about July. So plants have microbiomes, humans have microbiomes, rats, cats, dogs, frogs, everything has bacteria living on them. And this is basically just a summary of what I've basically just sort of tried to explain, where all bacteria combined with archaea led to eukaryotes, which ultimately led to plants and fungi and all animals. So what you can actually say, and it's been described that for every cell in our human body, there are about 10 organisms, bacteria. So in fact, you could say, well, maybe we're only 10% human, but that's actually a wild guess. It's not quite true, because you've probably seen that. They reckon that for every cell in our body, there's just over one bacteria. But what's actually more dramatic is that if you take all the genes from the bacteria, there are over 3.3 million genes compared to our 23,000 human genes. So in fact, if you're just thinking of humans as genetic material, we are less than 1% human genetically, and we over 99% bacteria, which is quite a frightening statistic. Now, there are about 100 bacteria that have been identified to make us ill, but there are thousands, possibly millions of different bacteria that at worst are harmless. But these have becoming recognized as invaluable parts of our body, and it's this hidden organ that we're now starting to understand. And just to go back a little bit, naturalists like Wallace and Darwin, they were the guys that sort of described evolution, but they were fascinated with this theory of islands and how everything evolves in different islands. And we're now starting to think of our bodies as separate archipelagos. So you've got your skin microbiome, you've got your urogenital tract microbiome, you've got your gut, but your gut is not just your gut, it's your mouth, your stomach, your small bowel, your colon, your rectum. It's all different. It's quite fascinating as we go into this. So just to talk about the microbiome, when does it actually start in the gut microbiome as humans? And I think a lot of you are gynaes and you probably all know about this, but at birth, before the baby's born, they're sterile. And 75% of the baby's bacteria initially comes from the mother. And as you know, there's a difference between vaginal births and cesarean births. And there was that fad at one point to take the swab from the vagina and then wipe it over the mouth of a newborn baby. And what's actually interesting is you heard at the beginning about something called Bifidobacterium lactis. But in fact, the first bacteria we get as babies are bifidobacterium. And that actually comes from the skin of the mother, or the vaginal tract of the mother. And bifidobacterium, and you mentioned there, bifidobacterium lactis, that these are basically bacteria typically designed to digest milk. And then over time, the babies they mature, and they start they're getting more and more bacteroides. And bacteroides are what they call complex carbohydrate fermenting. So these are the bacteria that start fermenting fiber. And by the age of around about between 1 to 3 years old, the baby's microbiomes change from bifidobacterium to bacteroides predominant. What are these bacteria doing? Well, they're helping to digest food. They're helping to absorb vitamins, minerals. They may break down toxins. They do produce antibacterial substances. They produce pheromones. You can just smell your armpits for that. Organogenesis, which we're going to briefly chat on, in terms of how the bacteria manipulate development of organs. They definitely play a role in immune systems, and they actually also play a role in animal behavior, which I'm going to talk about. And there's this whole thing in the past about the human genome that was sequencing our 23,000 genes, but now there's this whole thing about the human microbiome, and there's now the NHI microbiome project. There's the NIH Integrative Human Microbiome Project. There's pregnancy and preterm microbiome, onset of inflammatory bowel disease, onset of type 2 diabetes. In fact, you can go through a whole list of different studies going on at the moment, comparing urban versus rural, USA versus rural Malawi, and fat people versus thin people, health versus disease. But what I can tell you is that we don't yet have a single standard normal microbiome, because somebody growing up in rural Malawi has a completely different microbiome to somebody growing up in urban New York. And I just want to put a warning out there that when we start doing microbiome testing, and in Joburg, we've got labs, there are 3 labs now that are offering microbiome testing and testing you for dysbiosis. But I've got to ask you, what are you testing it against, and what is your norm? And if you're comparing it against a New York cohort, it's going to be different. It's dysbiosis. And if you're comparing it against Malawian urban or Malawian rural, it's different. And if you're going to test between Joburg and Cape Town, it's probably going to be different. So you've got to be a bit cautious when you're trying to interpret these reports coming out of dysbiosis.
Sorry, Peter, can I just interrupt? This is dysbiosis. Is this where you take a stool sample and send it to the lab and they culture, and then they just check and see what you have, and they give you some sort of comment? Is that what you're saying?
No. So there's now these new talks talking about the new stool panels that you can, they're testing for your 2,000 different bacterial microbiome, doing genetic R17 or whatever testing to identify your gut microbiome, and they're telling you you've got a predominant bifidobacterium or bacteroides, or a shift from fermenters to non-fermenters. So they're not identifying, it's not your that stool panel testing for 20 different pathologic bacteria. This is testing your normal bacteria, and then giving you a sort of a panel of where your bacteria are fitting in the sort of microbacterial realm, and which are your dominant good bacteria and which are your potentially pathogenic bacteria.
Is there any value in that, or are you going to tell us about it in a minute?
I'm going to tell you a little bit about it, yeah. Okay. But no, very little value at this point.
Okay.
It's very important in research. So at the moment, what they're looking at is fat people have different microbiomes to thin people. So yes, if you take a person who's got a BMI of 30, they are going to have a different microbiome to a person who's got a BMI of 5. But but the problem is what is normal? Is it the microbiome? Is it what's coming first? Is it the chicken or the egg? So you've got to be very cautious in interpreting these stool microbiome tests. But there is a role, and it is being looked at, and I'm going to talk a little bit about obesity. It's being looked at as a cause of asthma. It's being looked at in colon cancer. It's being looked at in diabetes. And what's even more interesting is autism. And I'm going to really just chat on autism and psychiatry, because I'm just going to pause here a little bit. And you talk about psychiatric illness, which is loss of self-identity, delusions of self-identity, experiences of alien control, are all considered markers of mental illness. But I'm just going to ask you, who's actually in control? Is it our microbiomes? What are we? Are we bacteria, or are we, what are we? And who's actually in control? Is it our microbiomes, or is it us? So maybe this whole microbiome talk is a little bit of a psychiatric talk, but I'm going to tell you a little bit about gut and psychiatric conditions, because they actually do coexist. So I'm a little bit tongue-in-cheek there, but the first story about gut and the mood came from this surgeon actually in America who described the so-called accidental orifice. And this was a patient who had a gunshot to his stomach and had a gastrocutaneous fistula. And it was Dr. Beaumont who described how the mood of this patient changed his gastric secretions. And he's been ascribed to the first person to talk about the gut, mood, gut, and gut-brain axis. And since then, we've realized that the gut and the brain actually go together. And I've just thought I'd describe this a study where, because I'm talking to mainly gynaes, this is a study going back to 2001, where pregnant mice were injected with a protein substance that's supposed to mimic a viral illness in the pregnant mice. And what they identified is that when they did this to the pregnant mice, their offspring are born with sort of repetitive behavior, grooming behavior. They bury their marbles. And this is actually an animal study thought to reflect autism and schizophrenia in the psychiatric literature. And what they've done with these mice is they fed them Bacteroides fragilis. And what they found is by giving them these mice, which is an animal marker for basically autism and schizophrenia, it actually improved their behavior. And what they were thinking is that by mimicking a sort of a viral illness in the maternal mouse, so the pregnant mouse, this has triggered an immune response in the offspring, where the gut, where the baby mice have a slightly excessively permeable gut. And this is now where this whole leaky gut story comes from. And what happens is they've worked out that these mice have an increased exposure to this 4-ethylene ethyl phenyl sulfate, 4-EPS. And by giving these mice Bacillus fragilis, they think that this actually normalizes the gut. And basically, Bacillus fragilis helps to actually ferment fiber. But it's then thought to make this gut less leaky. And now what they've worked out is in autistic kids, they are depleted in this Bacillus fragilis. So since the early 2000s, there's been an avalanche of, literally an avalanche of studies looking at the microbiome, particularly in sort of these mice and the whole microbiome and its role in autism, and how you can change mice behavior by giving them probiotics. And possibly, now we talked a little bit about fecal transplantation, using fecal transplantation in these mice to improve their behavior. So it stops them grooming and obsessive compulsive autistic sort of behavior. And what they've then tried to work out, can this be translated into humans? And this is now a study published in 2019 in Nature. So Nature is the highest impact journal in the world. So it's the #1 journal with the highest impact factor. And if you want interested, you can go look at the study. So they looked at long-term microbial transfer therapy in autistic humans. And what they found is that by doing fecal transplantation in these autistic kids, there was actually improvement. So if you look at the on the left picture on the screen, so picture A, at baseline, severe symptoms, and after 2 years follow-up, improvement in these kids' behavior. So this is the first human study showing that by manipulating the gut microbiome, you can actually change human study. But now, just to be water warning, this was a very intense study. It wasn't just giving them probiotics. They actually pre-treated these autistic kids with vancomycin, sterilized their guts, and they got basically weekly fecal microbial transfer therapy. So they got weekly fecal transplants for the first, I think, 8 weeks. And then they monitored these kids long-term after that. But this is the first evidence that we can manipulate behavior through fecal microbial therapy. So since then, it's now trying to be translated into everything. If you're fat, blame the bugs in your gut. And what is the evidence here? So this is coming into what these microbiome testing are talking about. So obese people have less Bacteroides, have more Firmicutes, and there's a bacteria that I'm going to show you a little bit later called Akkermansia mucophilia, or AKM, which you might hear, where they're given these bacteria to germ-free mice, and by giving this to them, it leads to these mice to lose weight. And it's thought that possibly after gastric bypass surgery, there's an increase in AKM, and it's not only the physical thing of the gastric bypass, it's actually the manipulation of your microbiome that also is leading to weight loss. But unfortunately, studies here in AKM have been inconsistent. But if you go online, you can buy your AKM. It's about 2,000 Rand a bottle. And here you've got Hailey Berry promoting it as a weight loss supplement. So this stuff is out there, and you're probably going to know a little bit about it. But it's not something that really has been proven to work. So with that as a background, what actually is a healthy microbiome? And the key word here is diversity. You actually want multiple bacteria. You want diverse bacteria. Because basically the diversity probably results in increased functionality. But the big problem is how do we measure this microbiome? And in fact, in the lab, we've only really got one proper marker that we've got at the moment, which is your calprotectin. So to come back, Peter, to your question about what should we be doing for microbiome testing, really you just want to know, is there abnormal inflammation? And the best test in your stool is just the fecal calprotectin. But in the future, we may start looking, I mean, in kids, they do look at fecal pH, but we might start looking at short-chain fatty acids. We might start looking at bile acids. We might even start trying to collect gas and work out hydrogen sulfide expression, etc. But at the moment, all I want you to remember is you want a diverse microbiome, and you don't really want pathologic inflammation. So this is just another example of what diversity is like. So it's just coming to the end of the flower season, but the picture on the left is really what you want. You want diversity. You want everything in your gut. The picture on the right might look beautiful, but that's actually a previously plowed field in Namaqualand, and that's just the first plants that have taken over. But that's sort of almost what happens when you get C. diff after an antibiotics. So you wipe out all your good bacteria, and then you get an overgrowth of your bad bacteria. Or you could even, if you're a gynae, this is what happens after antibiotic, and you're then getting an overgrowth of Candida. So you really need the diversity to keep everything in control. So coming back to that slide about what happens with your microbiome. So babies are sterile at birth. They get first exposed during their birthing process. And what they've showed is that breastfed babies have different microbiomes to bottle-fed babies. And then once solid food is introduced, the baby's microbiome rapidly diversifies and increases. And this is just purely because of the exposure to different foods. Now, with age, it's quite interesting. Your microbiome becomes sexually dimorphic at puberty. So at around about the age of 9, particularly in females, they start producing estrogen. And it's thought...
the girls start producing.
Yeah, so girls. So the girls start differentiating themselves from boys. And in fact, it's estrogen, they think, and I'm going to talk a little bit about the estrobiome, because you might have heard of that. Estrogen is thought to play a role in how the microbiome changes. And then as your sort of adolescents grow, your diversity increases and increases, which is thought to be related to your diet, lifestyle, medical conditions, etc. And your diversity peaks at the age of around about 40. And females have a much more diverse, or let's call it richer microbiome. So I mentioned that word diversity. So the key word here is diversity. So females actually have a more diverse microbiome than men. And then something strange happens. At menopause, female diversity changes, and it starts going back towards men. So what happens is postmenopausally, there's an increase in these various bacteria. Now, I've mentioned that I'm not good at pronouncing them, but you've got Prevotella, Serella, Dorea, Trichomonas are all increased, which goes back to what men are predominantly, and your Firmicutes and Rheumacoccus are decreased. So these are the studies that they've been looking at in postmenopausal females. And you mentioned there, or we talked a little bit about estrogen, and they think estrogen is actually one of the drivers of this diversity. And there's actually this positive feedback, and I don't know if you've heard of this term, the estrobiome, but estrogen is conjugated. So your ovaries secrete your estrogen. It's conjugated and deactivated in the liver, and it's actually then secreted as bile. But what they think is this deactivated estrogen actually may have a role in promoting sort of bacterial growth in the gut. And this increased diversity in the gut increases something called beta glucuronidase, which is produced by your gut bacteria. And then this beta glucuronidase actually deconjugates the estrogen in the gut, which actually then allows for reabsorption of estrogen. So it's actually upregulating your estrogen, which then increases the systemic estrogen. So the more estrogen you have, the more diversity, and then the more intrahepatic recirculation of estrogen. So it's this like positive cycle. And that then keeps promoting gut diversity. And then what happens at menopause when your estrogen levels drop, your gut microbiome diversity drops, you get your decreased action of your beta glucuronidase, which means that even your little estrogen that you've got doesn't get recirculated because you don't have any more of this beta glucuronidase. And you're now getting a negative cycle, and then your microbiome in females goes back more to a male microbiome. And changes that have been described, I'll mention these. The ruminococci are supposed to help ferment fiber and produce short-chain fatty acids. The Prevotella, Serella, Dorea are thought to increase, may have a role in weight gain. Your Oridobacteria also are short-chain fatty acids. And I didn't really talk about short-chain fatty acids, but short-chain fatty acids, going back to that mice model, are thought to have an effect on brain function. So short chain fatty acids are part of this thing that helps control behavior. But also increasing Aridobacteria means that you might find postmenopausal women complaining that they're a bit more flatulent. And I was talking here about the short chain fatty acids. Short chain fatty acids are involved in serotonin synthesis. They help with your neuronal stability, and they also thought to play a role in osteogenesis. So sometimes you may be the rheumococci that are decreased may not actually be offset by the increase in Aridobacteria, and it's thought that possibly decreased short chain fatty acid production may also contribute to osteoporosis, or the worsening of postmenopausal bone thinning. So this whole change of your microbiome in menopause is getting much more airtime at the moment, because it's got multiple effects. So it's not just the estrogen and hormonal effects that are causing a lot of the gastric symptoms in postmenopausal women. It's actually their change in microbiome. So the increase in hydrogen sulfide production may have an effect in basically resulting in a relaxation of smooth muscle. And it may also improve gut supply. So this is important in postmenopausal women, in that we often talk about irritable bowel syndrome in gastro, and then symptoms of IBS disappear as you get a bit older. And it may be related to the change in microbiome. On the other hand, the increase in hydrogen sulfide may lead to increased local inflammation, mucosal damage, and serum endotoxin. And I'm not sure if you're aware, but there's a second peak of inflammatory bowel disease in postmenopausal women. So women sort of between the ages of 50 and 60, there's another peak of Crohn's. And it's thought to possibly related to this change in microbiome that may predispose these women. So it's quite interesting. Also, in terms of the microbiome change may lead to a change in insulin resistance. It may lead, that there's research now looking at, as you get older, the change in microbiome leading to microglial activation, tau bodies, amyloid protein, and it's being implicated in Alzheimer's and other neurodegenerative diseases. And I mentioned briefly there a little bit about sort of osteoclast and its role in osteoporosis. So hopefully I've sort of showed you some of the practical information about what's out there and how it's becoming more and more relevant in everyday practice. But now the big question is, how can we improve our microbiome? And we heard a little talk at the beginning about Bifidobacterium lactis, and I'm going to talk about probiotics a little bit. But here there's this cartoon about the dogs. She's trying to work out what probiotics she should take, when she should just let the dog lick her face. And it's quite interesting. I mentioned that the key at the moment, and the key word in your microbiome is diversity. And this is a study from the American Gut Open Platform for Citizen Science, where they're looking at microbiomes in basically, these are volunteers that are prepared to send their stool off for testing. And what's fascinating is that they've showed that there's a sort of a point where your microbiome is the most diverse. And basically what we are supposed to be doing is not necessarily taking probiotics, but what you should be doing is eating plants and different plants. And there's this 30-week plant-based challenge on the internet at the moment. You can go look for it. But bottom line is we should be trying to diversify our plants. And if you're eating more than 30 plants a week, it actually doesn't matter if you're a meat eater, if you're a vegetarian, if you're a pescatarian, so long as you're getting enough plants in your diet to feed your bacteria, you will then have a diverse enough microbiome. But as soon as you're not having this 30 plants a week, your basically your diversity decreases. Now 30 plants
are those 30 different varieties of plants, or 30 plants, 30 different varieties?
30 different varieties. So but if you think about it, it sounds a lot, but it's actually not. So I don't know if you're trying to work out what you had to eat today, but if you've had bread, you've had wheat, you might have had some nuts, you might have had I don't know what else I've eaten, but soya, salad, is lettuce, tomato. You've probably already done 10 to 15 different plants. And when you go home tonight, just count how many plants you're actually eating. But it includes nuts, it includes breads, it includes fruit and vegetables, grains, etc., etc.
Peter, can I just interrupt? We're getting a few questions coming through, and I don't want them to wait till the end. Rupert Moodley says, number one, you've mentioned the menopause and hormonal therapy. Is there a new role for microbiome supplementation in there? And the same person asks, antibiotics you mentioned. If a person's on long-term antibiotics, for example, acne for teenagers, is that a terrible idea? Or can you alter the microbiome by adding different probiotics and so carrying on with your tetracyclines?
So those are excellent sort of questions. And I'm hoping to, I think your diet is actually more important than your trying to manipulate, because the trick is diversity. So the probiotic that we got taught about in the beginning here, the study that she quoted is actually just 14 days of a probiotic. And I'm going to talk a little bit about probiotics now, if you don't mind.
No, we're very keen.
So I'll get onto that, yeah. But before I get to there, just to tell you about diet. So fiber, we used to learn it was the broom to just give you something to help with your constipation. But fiber is actually what bacteria use to break down. And I mentioned about the role of short-chain fatty acids. So it's actually your fiber in your diet that comes from plants that basically is what's feeding your gut bacteria.
What fiber do you mean, Peter?
So fiber is basically in your you get soluble and insoluble fiber.
Yep.
So it's basically all your plants. All plants have a base of fiber, and you've got soluble and insoluble fiber. You get plants that have more fiber than others. So that's your whole wheat breads and your vegetables, and probably the skins on your fruit, etc., etc. That are not just the carbohydrate, it's the actual scaffolding of the fruit. Whereas meat, it's the protein that makes the foundation of meat, whereas fiber is what goes into most of your vegetables.
Is that like cellulose? You mean like cellulose?
Like cellulose. So cellulose is a type of a fiber, yeah. If that makes sense. So it's the plant-based stuff that's the scaffolding of all plants is fiber, basically. Cellulose, psyllium, all of that stuff is fiber.
You can buy that stuff at Dis-Chem in a pot, in a plastic bag. It looks like sawdust.
Yeah, that's psyllium husk or Metamucil or Espiguana husk.
Is that for constipation, or is that a good idea to take that with your wheat pix?
So, well, wheat pix is also fiber. So,
yeah,
but it is. So the psyllium is a bulking agent, and it does feed your gut bacteria, and that does promote motility.
Okay.
And basically what we found is that Westerners that are eating highly processed foods are having a low fiber diet. So as we eat more and more pre-cooked, ready-made food, our microbiome diversity is decreasing. So coming now back to that question about probiotics, who wants to colonize? So we mentioned right at the beginning, bifidobacterium. She mentioned bifidobacterium lactis. There's the first one that babies get is something called bifidobacterium infantis. And what bifidobacterium actually does, you might remember human milk. is basically, at medical school, we learned about fats and protein and lactose. But how many of you can remember the HMOs, the human oligosaccharides? And basically more than 50% of milk is these HMOs. So half of breast milk is actually HMOs. There's more HMOs in milk than protein. And basically we know babies can absorb fats, protein, lactulose, but what is the other 50% of milk for? And what it is HMOs are there to feed the baby's the gut microbiome. So HMOs are actually the fiber. So you asked me about fiber. HMOs are the milk fiber for the bacteria. And it's these HMOs that are broken down and they produce short-chain fatty acids. And then it's these short-chain fatty acids that are taken up by the gut and the brain. And these HMOs, human milk oligosaccharides, are only found in breastfed babies. So this is why they're now giving preterm babies, it's preferred to give them human breast milk with various probiotics, specifically Bifidobacterium infantis, to try prevent NEC. And it also may help with maturing of these prem baby lungs, etc., etc. And if there are a whole bunch of obstetrics and gynaes here, you'll probably know more about this. But this is the reason why they want to use human breast milk as opposed to bottle-fed babies. So that's
infant formula. You know that you even get an infant formula nowadays for cesarean delivered babies, and it's full of probiotics. But the problem, and you might be able to talk to about that, but the problem is, which probiotics do you use in this particular case?
Yes, no, exactly. So what happens is it's Bifidobacterium. So what they were mentioning right at the beginning is she was talking about Bifidobacterium lactis, HN019, which is a substrain of Bifidobacterium. But basically, Bifidobacterium are there to help human babies digest breast milk. Then you get Lactobacillus, which is the other main probiotic the other main bacteria in probiotics. And the reason why they're in probiotics is that they're hardy and they survive passage through the gut. That's really probably the only reason. But they are air tolerant, so they can sit on a shelf. They are found, so Lactobacillus is what actually you find in your, and I think they mentioned a specific probiotic that may help with vaginal candida. But what you're trying to use there is Lactobacillus, because that then outcompetes candida in the female urogenital system. And it also outcompetes candida in the gut. And in the female, it helps to produce lactic acid, and it controls vaginal pH, thereby sort of trying to control candida in the gut and in the thing. So when you're looking at probiotics, it's a good question. You're asking about Lactobacillus and Bifidobacterium. And if you look at these multi-strain probiotics you buy, the best multi-strain probably that's got the most data is VSL3 or Vivomix. And that one is classified as a multi-strain probiotic, but actually what it is it's a combination of Bifidobacterium substrains and Lactobacillus substrains. The first one that we heard about tonight was Lactobacillus lactis, which is a single strain of Bifidobacterium. And what the Cochrane review has showed is that, yes, so any probiotic will shorten your risk of infectious diarrhea. It does possibly reduce side effects from antibiotic-associated diarrhea. In the gastro literature, it's been shown that combining it with your triple therapy does possibly increase H. pylori. It has been shown in preterm infants to reduce necrotizing enteritis. But I talked about the whole stuff in the beginning about in terms of its role in psychiatry. A single probiotic has not yet been shown to make any difference in allergies, asthma, eczema, obesity, diabetes, autism, schizophrenia, depression, menopause. It has, as that study showed, it was in the beginning, it may have short-term improvement in gut symptoms. And we think it happens because of it increases intestinal motility. So short-term, putting a high-dose probiotic may act as a mild laxative, but the problem is if you go longer than 14 days, the effect starts to wear off. And I think what happens is that the probiotics act as a starter to help with diversity. So after you've had an antibiotic, putting in a probiotic helps the bacteria to go back. But if you keep using a probiotic, you actually then start suppressing your other bacteria. And you start now, and I remember I said the word is diversity. You actually stop the diversity of your gut expanding. So long-term probiotic use is probably not a good thing. But definitely intermittent short-term use is where it's at the moment. In terms of long-term antibiotic therapy, yes, while you're on an antibiotic, it's probably not a bad idea to have a probiotic. So that question about acne or long-term probiotic, a long-term antibiotic therapy, especially if you're having side effects, putting a probiotic on board will help to outcompete things like Candida and possibly maybe reduce your incidence of C. diff, etc. So there is a role there for long-term probiotic. Short-term probiotic for short-term intervals may be useful, especially in people with non-specific GIT symptoms. But as a long-term health supplement, I don't think there's any major role for probiotics.
Peter, can you just go back one slide? That's it. Now, that last line of yours, the obstetricians over here have been told many a time, we've been hit with a whip that says if you do cesarean sections, you are increasing the incidence in babies born to cesarean section deliveries, more allergies, more asthma, more eczema, more obesity, and more diabetes. It might, in fact, not be the Caesar that's causing that. It might be the change in the actual microbiome associated with cesarean deliveries that may be associated with changes and high incidence of those diseases. So had you been able to give the correct microbiome, you wouldn't have those increased incidence of those conditions.
Well, that's where that theory came, where you take a vaginal swab and then brush it over the child.
Because we don't do that anymore, because somebody tried that and gave the baby herpes, and the baby almost died from herpes sepsis. So we don't do that anymore. But I get, it sounds intuitive like a good idea, but I think that many good ideas don't have a scientific basis to them.
No, but you see, you can make the same argument for all of those antibiotics before the age of 3 are also linked with increased incidence of autoimmune diseases and atopic diseases.
Yeah, sure.
So is it the Caesar? Is it the antibiotics?
Is it the microbiome?
Is it the microbiome? Is it the breastfed mother or the bottle-fed mother? So it's multifactorial, but I think all of these are actually playing a role.
Yeah.
So you asked a bit about specific probiotics, and we had a talk at the beginning about a specific strain of probiotic, and there is some very interesting data looking at in irritable bowel syndrome. And yes, we often do. I'm a bit jaded as a gastro because by the time the patients have come to me, they've failed everything that's been thrown at them. But you definitely do get a short-term change in GIT symptoms. So yes, a short course of a probiotic is definitely worth a try. They're looking at Bacteroides fragilis as a type of anti-inflammatory probiotic. I showed you the picture of AKM with Halle Berry as a trial for trying to control weight. But now we've got much more powerful anti-obesity drugs. And then there's another one that you might have heard about, Fecal Bacterium prausnitzii in inflammatory bowel disease. So these are all sort of single strain probiotics that are being looked at. But as yet, there's no definite recommendation. So now we talked a bit about fecal transplant. So this is Chuck Norris, and how many press-ups can he do? He does all of them. So we talked about diversity. So why aren't we? So the future is going to be in fecal microbial manipulation. So fecal transplant is not just 1 or 9 of them, it's all of them. And so I work at a transplant center here in Joburg at Donald Gordon. We do the livers and kidneys, and I'm the only one who does a transplants without having to do any surgery. And this study that we present, that was published in 2018 in SAMJ about our experience. That was our first, I think, 29 patients that we did with resistant C. diff. So they'd all failed vancomycin therapy. And all of them ended up with fecal transplantation. We actually did fecal transplantation by nasogastric tube in these patients. But you can do via either nasogastric tube or via colonoscopy. And the first 29 patients, we had 100% cure rate in terms, and that's sort of similar to literature. The literature is around about 90 to 100%, depending on where you look. We've had a couple of failures in C. diff fecal transplantation. But I'm going to present some here a little bit from the gynae point of view about fecal microbiome, fecal FMT in vaginal atrophy in overrectomized mice. So what they've done is they've taken out the ovaries in these mice. And so we talked a little bit about estrogen, and what they showed is that by giving them fecal material, so diversifying their gut microbiome, it actually managed to reverse the vaginal atrophy in these overrectomized mice. So I'm almost running out of time there. So I don't know if I've helped and sorted out your pelvic floor, but I hope...
You certainly have. Now, on that very slide, on that very point, Peter, there is a new, brand new preparation called GynaFloor, which is estrogen plus probiotics. So it's actually aligns itself entirely with what you've said recently, just now. So it's estrogen plus the probiotics used vaginally, topically. So, that sounds like a jolly good idea, doesn't it?
No, it does. So it's this whole concept of this estrobolome and the role of estrogen in trying to improve the diversity of your gut bacteria. At the moment, so one of the big questions is fecal transplant the cure for everything? And the answer is absolutely not. So unfortunately, we get a lot of requests, often actually from doctors and doctors' wives, that they want their rheumatoid arthritis cured with a fecal transplant, or their psoriasis treated with a fecal transplant. At the moment, that's not recommended. The only real indication for fecal transplant is resistant C. diff.
Yeah.
And we have done it in patients with pan-resistant sort of bacteria. So we had as an example, was a patient who had a enterovesicular, so a fistula. She was a Crohn's patient with a small bowel bladder fistula, and she kept getting recurrent bladder infections, and she was actually resistant to every antibiotic that we have. And out of desperation, we did a fecal transplant on her. And we've managed to now restore some sort of antibiotic sensitivity to her in terms of trying to treat her sepsis and prevent her from getting drug sensitive. So there is a role probably for fecal transplant in multi-drug resistant bacteria infection. So those are the really only two indications. In gastro literature, there's a lot of interest in fecal transplant, in particularly ulcerative colitis, and how we can put a normal gut bacteria. And I'll just tell you an interesting thing. So I'm talking to the sports physicians later this month about fecal transplant, but in the Scandinavian countries, they've created stool banks. So you can get so you talked about how difficult it is to get a fecal transplant in C. diff, we don't have a stool bank in South Africa, so we have to go and find donors. But I think in Norway, they've screened their Olympic team, and they've got super donors, and their super donors are classified as vaginal birth, no antibiotics in the first 3 years of life, no neurodegenerative disease. They're all Olympic athletes, and basically they mustn't have had any antibiotics in the preceding 6 months. And those are their stool donors. And they are using those donors for their fecal transplants. In South Africa, we just we have patients, and then we ask them to go and ask their friends or their relatives if they're prepared to be screened. And all we do is screen them for we do that gut panel, the GI panel, checking for all sort of gut obvious infections, including C. diff and H. pylori. We screen them for syphilis, HIV, and hepatitis, and then we take their stool and we literally mix it up in sterile saline, a fresh stool from the morning, mix it up in sterile saline. You can either put then a nasogastric down, and we put in literally 100 mils of stool via nasogastric tube, or we go via colonoscopy and inject then normally, but they're actually 60 mil syringes. So we go and put in 120 mils, in 60 mils into terminal ileum and 60 mils into cecum. And that's how we do a fecal transplant. And with good effect in C. diff. What the studies are doing in terms of trying to treat IBS, they're either doing it via nasogastric or in inflammatory bowel disease via colonoscopy.
Peter, it sounds like an interesting thing, but expensive. Can't you just put it in a capsule and then swallow a couple of capsules? I mean, that tastes like shit. But let's assume that you don't actually bite on them. Surely that helps, or is effective?
Yeah, so the problem comes to capsularized stool. So I mentioned there the reason for lactobacillus being a probiotic is that it can survive on a shelf. The problem with your stool is that a lot of the bacteria in our guts are actually anaerobes or microaerophilic. So as soon as they get exposed to the air, they die.
Oh dear.
And you can't keep them for long. So it has to be fresh. Yeah. They are doing fresh frozen. So the stool banks are freeze drying your stool. So they're getting a donor, they're preparing it into a liquid, and then they're freezing it. And bacteria actually don't necessarily die from freezing. Oh. So long as you, and this is the problem with fecal transplant, is that it's actually, it's so crude that there's no real standardization. And so you're really doing fresh stool, or you have to have freshly frozen stool. But once you try to capsularize, now, believe it or not, there is an FDA-approved fecal capsule, and it has been now FDA-approved for treatment of C. diff, where they have capsularized and put it into a stool, but not yet available in South Africa, and it is very expensive, costs similar to fidaxomicin.
Wow.
Which is a bit silly, but it's that's how much they're costing. But because of the whole process of trying to preserve the bacteria, and when you're preparing it, it's got to be in a sort of a oxygen deprived environment. So it's not so straightforward as taking crap and then putting it in a capsule and then putting it on a shelf. That by then most of the bacteria would have died.
No, you see, it's a stool transplant. I'm sorry, we ran out of time, but a stool transplant does sound, as you say, very low tech. And it's sort of almost a do-it-yourself thing that you can do in your garage. But I suppose...
No, you laugh. That's what patients do. So you can go onto TikTok or YouTube, and you can borrow your brother's or sister's or boyfriend's stool, and people do that, believe it or not. And they give themselves they give themselves a stool enema. So you can go onto YouTube and you can work out how to do it. And what's quite interesting is the vets have been doing this for years. When we first started doing fecal transplant, I was surprised that there's a study from the 1970s when they were translocating giraffe from the Kruger Park to the Tuli block in Botswana. And what the vets do there, they take crap from animals living in the Tuli block and feed it to the giraffes to try and get their microbacterium used to eating the different trees from Kruger Park versus Botswana.
Wow.
And this is something that's done routinely in veterinary practice. So when you're transplanting, when you're moving animals from one part of the country to another part, they actually take stool from whatever animals that have been living there, and they let these animals eat that stuff.
My dogs do that as well, but they're not transplanted.
No, exactly. So it's only humans that are worried about sterility.
Yeah. Well, Peter, it's been wonderful.
Crude, but it's unfortunately we're going backwards with this medicine in a way.
Yeah, we are going backwards. It's a subject which is very close to your heart, I can see, and it's been wonderful having you over here. I'm sorry that we've run out of bandwidth, but maybe we can ask Belinda and Metagenics to get you back in the near future after your sports science foray for the athletes. And we're going to be talking on something maybe more focused on the menopause and the microbiome in newborn babies and things. It's a fascinating subject. We've got lots and lots of people that have logged on and lots of very good questions. So I'd like to thank you very much indeed, Peter, on behalf of the Cape Town the Pelvic Floor Society and the Pelvic Floor Foundation, and Belinda of Metagenetics. It's been wonderful having you here. And thank you very much indeed.
Well, thank you very much. And thanks for inviting me.
And to all of those people that's with us, we go same time, same place next week. And thanks again to Chris for setting everything up. All the very best to you. Safe home, Peter, and and keep safe and keep sterile.
Oh no, let your dogs lick your face. Yeah, cheers.
Yeah, sure. Thank you, Pete. Bye-bye.
Cheers.